Good afternoon and welcome to this edition of In Depth Alaska. I'm Tracy Sinclair, and October is, of course, Breast Cancer Awareness Month, and really some good messages that we've been talking about over the last couple of weeks, and excited to get some new information out there for today. So I'm excited that I have two really interesting experts with me for today. Sharisa Hayberger, she is with the American Cancer Society, and Dr. Kendall Webb with Alaska Oncology and Hematology. Thank you both for joining us. We really appreciate this because there's a lot of overwhelming information sometimes. And Sharisa, let's start with you. Kind of give me an idea of where we're at with like numbers for breast cancer patients and breast cancer diagnoses in Alaska.
When it comes to new breast cancer cases in Alaska this year, breast cancer ranks number 2 when it comes to incidence when genders are combined. Number 1 is prostate cancer, but when men are removed, breast cancer is number 1 for women. About 540 women will be diagnosed with breast cancer in 2024, estimated. And then when it comes to mortality, breast cancer ranks number 5 in the state of Alaska, behind lung cancer, colorectal cancer, pancreatic cancer, and liver cancer. About 60 Alaskans will be lost to breast cancer this year.
And so when we're looking at not only compared to Alaska, but looking at overall, how do we compare to the lower 48? Are we about on par with what we're seeing in other places?
In both incidence and mortality, actually, Alaska is a little bit lower than the national average, but quite close.
And I just want to say that I know we are streaming live on our website. We are looks like I'm having streaming issues on Facebook, so we'll have to catch up with some of those comments later. I'll actually figure out a way to get this posted so that people that wanted to watch it on Facebook, because it does look like I'm having some issues getting on my stream there. So Dr. Kendall Webb, you, as I said, are with Alaska Oncology and Hematology. You said you're born and raised here in Alaska, and that is so wonderful that you came back to the state to help treat patients in Alaska. When I was diagnosed with breast cancer, this was 2012, so a good while away. The words my doctor said to me were, "You're a young woman with a curable disease." And I was like, I like both sides of that phrase. That just made me happy. I know a lot has changed, and where they're continually updating different kinds of treatments and technologies. As somebody who deals with this, what do you see are the most interesting and up-to-date, fascinating technologies and treatments that we're seeing?
Yeah, so there's quite a few. I would say that to begin with, one of the most exciting things for patients is that we are now just starting to utilize circulating tumor DNA for breast cancer. We already use circulating tumor DNA in other cancers, colon cancer, for example, to help dictate whether or not patients are getting adjuvant treatments or not. But for breast cancer, it's still in the early stages. Now, circulating tumor DNA, in case, for those of you that do not know what that is, it is a tumor-informed assay where you are essentially taking the original tumor block from that patient, from that pathology, and you're looking for tumor DNA. So all cells have DNA, so do tumor cells. And when we compare those genetics from the tumor block with the patient's blood, we can be looking for that tumor DNA. And if we know that if we find that tumor DNA, that is strongly predictive for recurrence. Now, like I was saying, though, it's not quite prime time. We still need to tease out some of these patients and what it means when we don't have positive imaging along with these blood tests. But what's exciting about that is that the hope would be that in the future, we can have treatments for these patients. We can say, listen, we know they're going to recur, within 8 months to 3 years. It looked like that was the lag time. What should we be doing about these patients? Should we be treating them earlier to be sure that they have a longer time to progression? So that is probably one of the newest technologies that's the most exciting. But there are others. We're doing more and more contrast mammograms and MRIs for screening breast cancer. of course, alternating with standard of care annual mammograms. But these are mostly for patients with very high risk disease, strong family histories, our BRCA patients. So those are just a few of the technologies, but I can touch on the treatments if you want as well.
Well, I do, but first let's jump back. Sharissa, we were talking earlier about, as Dr. Webb just mentioned, mammograms. What is the current idea around who should get them, when should they get them? Are there certain demographics that breast cancer is going to hit more often, that more people should be concerned? What's the current working theory?
For women who are of average risk, the current recommendation for screening is to begin talking to your doctor and choosing to get a mammogram if you like, starting at age 40. At age 45, the current recommendation is that every woman should be getting an annual mammogram starting at age 45, all the way through age 55, when a woman could choose to get a mammogram every other year if they'd like. And that, again, that's for women of average risk. Women who are at higher risk of breast cancer should be having conversations with their doctor much, much sooner and begin screening sooner as well.
I hit a wrong button and I also forgot to turn my mic back on, so I apologize. So Dr. Webb, you were talking about new treatments. When I was going through it, I don't think Herceptin at that time was a new treatment, but I know that it was, I understand it was something that was developed with the American Cancer Society. So thank you guys for doing that, because I was HER2 positive. So what are the new treatments? What should, I guess, give people hope that if they are diagnosed with breast cancer, it's not life-ending, it's not as horrible as what I think some of us have in our brains, because there are so many new treatments out there.
Oh, goodness, yes. So actually, around the time probably that you were diagnosed, Oncotype DX was really starting to be utilized, like with almost every early stage breast cancer patient that had hormone positive disease. So that was one of the newer assays to help tell us which patients need chemotherapy and which ones can we de-escalate and don't need chemotherapy and do just as well. So fast forward, now we actually, we are starting to use, so there's drugs called CDK4/6 inhibitors, and we've already been using them in the metastatic setting for hormone positive patients. We've been using them for a while now. And there's one in particular called abemaciclib that we have been using for really high risk, early stage breast cancer hormone positive breast cancer patients. But what just happened this past year is that we have this trial called the NATALEE trial that showed us some updates. And what's exciting about this is it included node negative patients. So those with lymph node negative, but perhaps other high risk features, in their pathology and in their staging. And we're seeing that actually there's more and more patients that are benefiting from the CDK4/6 inhibitors, not in the metastatic setting, but also we're using it in the adjuvant setting. So adjuvant meaning after the definitive treatment of the breast surgery. Typically, these patients, historically, they would only be using endocrine therapy for 5 to 10 years. But now that we have newer and newer evidence showing that there are some patients that are benefiting, even if they don't have lymph node positive. So that's an exciting new drug. Ribociclib was the trial drug for the NATALEE trial. But like I said, we've already been using abemaciclib in that setting. For early stage, that's just for early stage hormone positive, but for early stage triple negative breast cancers, I think probably the most exciting thing in the last few years has been the inclusion of immunotherapy. Keynote 522 really allowed us to start doing that. So we use immunotherapy, things like pembrolizumab. We use it in both neoadjuvant and adjuvant setting for higher risk triple negative cancers that are curable. So, pembrolizumab was one of those things when I was in training, that was only a drug that we used for metastatic and only in a few different cancers. And so the fact that we fast forward and we're already using these medications in neoadjuvant setting because we see that there's benefit to patients and patients are living longer and doing better is amazing. And I didn't even get into the metastatic. I can talk metastatic too if you want.
Well, as somebody that treats patients and deals with this on a daily basis, when somebody, I know I've gone through it, you get there, you're scared, you're terrified. How do you talk to somebody and say, listen, there are so many ways that we can treat this? How do you comfort somebody? Or how do you tell them it's going to be okay, or you're going to work?
Yeah, of course. And that is something that I think is more of the art of medicine. I think it's really important to find where your patient's at, because not everybody is coming into the office in the same headspace. Not everybody has the same support, the amount of support that they have. So there's so many variables that play into that. But what I first try to do is really try to get into the mindset of where my patient's at and try to fill in some of those gaps, because most patients that are walking into the office these days, they've looked online, they've talked to their friends. They're 1 in 8 women are getting breast cancer. It's not so uncommon that you may not know somebody. So I try to be on people's levels, but I also just do exactly what you were saying, encourage patients just by saying that showing them the data that, listen, look, this is not a death sentence anymore. I mean, like, even those patients with node positive cancers, the fact that we have, so example, like those node positive cancers that I was talking about earlier, some of those patients weren't included and don't fit criteria to get chemotherapy. So the fact that just the fact that we have newer medications coming out on an annual basis, basically addressing these issues and addressing that specific patient population it's not only exciting. I mean, it's life. It's life to patients. It gives them more time, and that's everything.
And Sharissa, everybody else can't see you, but I see you nodding along with what Dr. Webb is saying. You probably have to deal with people calling saying, I just got diagnosed with breast cancer. What happens now? How do you help people through this?
Yeah, Dr. Webb and her colleagues are the ones who are actively saving lives every single day. And here at the American Cancer Society Alaska, I like to say our job is to help people get to and through their treatment. So when we pick up the phone or when someone walks through our doors, they might just need someone to talk to. They might just need emotional support. But a lot of times, especially in Alaska, they need solutions to getting to their treatment. So things like free transportation to local appointments, and then free flights and lodging for patients who have to travel far from home to receive treatment is a large part of the support that we provide to Alaskans facing cancer.
Well, as we're looking forward, we're getting to the end of October, and I know we highlight breast cancer awareness during this month. Dr. Webb, what do you see on the horizon? What is most exciting to you as somebody that works in this field that you think is the most positive thing that you see coming through?
Oh my goodness, there are a lot, but let me just give one example of this medication. So there's trastuzumab deruxtecan, which is an antibody drug conjugate, and I don't know if you heard the trastuzumab portion of that. So that's historically, these were HER2 medications. These were only used for patients that had HER2 positive disease. Now, with this drug alone, we have sort of changed our ideas on what HER2 even means. So we have learned that this medication is not only useful in HER2 positive patients, but it's also useful in patients with HER2 low or lower expressions of HER2, where historically these patients were just considered HER2 negative. Being a HER2 low, these patients are now being included in treatment with trastuzumab deruxtecan. And we're seeing that these patients do a lot better. And they do a lot better even if you give this trastuzumab deruxtecan before chemotherapy, which is just mind-blowing. It may not sound that exciting to you, but what's exciting about this is, I mean, we're almost having to go back to a pathologic standpoint with breast cancer in our understanding. And maybe we've understood HER2 to be, not just negative and positive. We always understood it that way, but now we're seeing it's more of a spectrum, and that's wonderful, because that means that there's a lot more patients that may benefit from these medications, from medications that are already out there. The other thing I think is very exciting is that we're using next-gen sequencing more and more. So next-gen sequencing is really just like a genomic profile of the tumor cells, of that tumor DNA. And if you find specific targets on the tumor DNA, we have more and more medications that are coming out that target these specific mutations. So, for example, PIK3CA mutation, we've known for years that there's a drug that can treat that, but there's now a newer medication that targets the PIK3CA that also targets 2 other mutations. So the fact that this is what this means to me, is that we're just including more and more patients into the possibility of being treated with targeted treatments, which we hope, and they tend to have more like lower toxicities and better survival for patients. So better survival, lower toxicities, that is all we are looking for as oncologists. We want people to live as long as possible with the best quality of life.
Yeah, that's just amazing. Like I said, I get all teary. Sorry when I think about it. But because we really appreciate the work that you guys do. Okay, I'm done. I'm done getting all emotional. But thank you guys both for joining me here. Sharisa Haber with the American Cancer Society and Dr. Kendall Webb with Alaska Oncology and Hematology. New and exciting things in breast cancer treatments, and always working to move forward. I know, as I said, just from the 12 years since I went through it, like people that I know are doing completely different things than the treatments. So we do appreciate all the work that you guys do. And thanks for talking to us a little bit about some of the new things that are out there and on the horizon.
Thank you for having us. And remember, you're a survivor. You did all the hard work.
No, I just had to sit there. Thank you guys so much. And thank you all for joining us here on In Depth Alaska. And we'll have more on different topics that Alaskans care about across the state.